Good evening, everyone. I'm Dr. Gaurish. So it's been ages since I made an academic-oriented lecture on my YouTube channel, and eventually I noticed that I was getting a lot of messages on my email and also on Instagram, where a lot of students were asking me to please keep continuing. And though I have been receiving messages since last 2 to 3 years, I really did not find much time. Uh, but I'm very happy and satisfied for the response that I've got, and I feel very good for whatever I've done. I started this page as a mnemonic video channel after my MBBS when I was preparing for NEET PG exam, and I got a very good response for all the mnemonics that I made. But eventually, after I made about 60 videos based on mnemonics for NEET PG exam, I was done with all the mnemonics that I had. But later, when I took up MD radiology residency, I made few lectures on radiology, imaging, and other things. Even that got some good response. Right now, I'm an intervention radiology resident. I finished fellowship in neurointervention, and now I'm doing super specialty in endovascular intervention. I bought this topic here because left-sided portal hypertension is a rare thing, and most of us have never heard about it during our residency. Mostly because these were not adequately treated and not fully managed, I can say. But with the help of intervention radiology and its techniques, where we use imaging tool to recognize the rarest of rarest things and treat them efficiently, is something that I'm very fascinated about after taking up intervention radiology. So in this video, I'll be giving a lecture on left-sided portal hypertension and how an intervention radiologist can cure this and how we deal with it and also the techniques we use. And you will know that most of the things can actually be handled through imaging guidance efficiently. See, most of the time what we know is that liver cirrhosis leads to portal hypertension. But what is left-sided portal hypertension? This is something we never heard. So here, if you measure the portal venous pressure on ultrasound at the liver parenchyma, the pressure is usually normal and the portal vein is not dilated also. But if you go to the left axis of the portal venous circulation, it is showing hypertension. And this is mainly because of splenic vein stenosis or occlusion. This is most famously uh, recognized as sinistral hypertension. This is a common term used in medical science. Everybody calls it as sinistral hypertension. You can also call it as regional portal hypertension because it's confined to the left side of portal mesenteric circulation. So let us understand the physiology of how the blood flows in the portomesenteric circulation. So this is the spleen. The blood from the spleen gets carried through the splenic vein into the portal vein and into the liver. Similarly, the blood from the colon flows into the superior mesenteric vein, into the portal vein and the liver, where rest of the process of detoxifying the blood happens in the liver. So this is the normal direction of flow. You can see the flow is always directed towards the liver. So what happens in sinistral hypertension is that you can see that the splenic vein is thrombosed. Why it's thrombosed? Most common cause is pancreatitis. What happens when there is pancreatitis? There is inflammation of pancreas. There is surrounding collection. This results in inflammation of the surrounding vessels. So spleen is the closest vein to the pancreas. The splenic venous wall goes for inflammation. This results in establishment of prothrombotic state, and hence the vessel gets thrombosed. So when the splenic vein is thrombosed, you see there is artery, splenic artery bringing blood into the spleen, but there is no outflow. The outflow of the splenic vein is thrombosed. Now the blood has to find a alternative route to reach the liver. So what it does, it re-establishes the collaterals. Most commonly, the short gastric vein over here gets re-established, the posterior gastric vein gets re-established, and all of these veins starts re-establishing flow, results in the formation of gastric varices, esophageal varices, and the blood is directed through the coronary veins into the portal vein and eventually into the liver. But this is an alternative pathway, and you see these vessels are abnormally dilated because they cannot handle the amount of pressure that splenic vein can handle. So they go for tortuous dilatation, and once the pressure is too much, these vessels can go for rupture and eventually hemorrhage. Similarly, on the other side, the blood can also flow reversely through the gastroepiploic vein into the superior mesenteric vein, and this back pressure is transmitted into the colon, results in formation of colonic varices, where if the colonic varices ruptures, patient can also have bleeding through the rectum. So why is this important? Is that development of these collaterals can result in formation of gastric varices or esophageal varices and even colonic varices, When these varices rupture because their vessels cannot handle the amount of pressure that a splenic vein or supramesenteric vein can handle, it results in formation of it results in upper and lower GI hemorrhages. These hemorrhages can be life-threatening. So what happens when it ruptures? Patient can either vomit blood, which is called as hematemesis. Patient usually vomits out bright red blood because you can see the gastric acid brings about oxidation of hemoglobin and it's usually coffee ground color. Patient can have melena. He can pass black tarry stools which contains partially digested blood. So eventually when these processes take over, patient's hemoglobin drops, patient loses blood, his vitals go down, he develops hypovolemic shock. So sometimes it can be an emergency condition also because when the large gastric varices ruptures, patient starts vomiting out lot of blood and patient can land up in the emergency with hypotension. So a decade ago and even now, what we do is whenever a patient with hematemesis or melena with esophageal or gastric varices comes with bleeding, patient usually goes to gastroenterologist. So what they have been doing since last 2 decades and even before is that they use an endoscope to treat this. So this is the endoscopic view. You can see that there are gastric varices behind the mucosa and the mucosa, you can see how the veins are all dilated. They recognize these veins and they apply a band across it. This is called as endoscopic banding. So this is the most common thing they do. Another thing, other options for these things is that they can also go through the endoscope, put a needle inside the varices and inject some amount of glue injection. So the glue, what it does, it embolizes the varices and it patient stops bleeding. But how efficiently can this be treated? You can see that there are so many varices and not every varices can be dealt in a single session. And there are some varices that is submucosal which cannot be seen through endoscope. There is some surgeon's role also in all of these cases. What they do is they take out the spleen. So this was a very traditional technique. So patient comes with left side portal hypertension, you take out the spleen. What happens when there is no spleen? Obviously there is no blood flow and there is no outflow through the splenic vein. Eventually the splenic pressure comes down and patient's left side portal hypertension resolves. This is usually done when nothing from the endoscopy is dealt and then they do splenectomy. But we all know when patient undergoes splenectomy, patient also lands up in the risk of infection, various pneumococcal infections, and we don't really want to take that risk in a patient who's already having other problems. So these are all traditional techniques, but what the purpose of this video is that what an intervention radiologist can bring to the table in dealing with such conditions. What we can do is we can embolize these bleeding varices. As an intervention radiologist, we can use the digital subtraction angiographic cath lab suite. We can recognize these varices and we can embolize all the varices in a single session. As I said, you see, the endoscopist cannot see some of the varices that is submucosal, and he cannot deal with all the varices in a single session. But the advantage of being an intervention radiologist is that we can see all the varices through DSA, and we can embolize all of it in a single session. The next thing we can do is we can also recanalize the splenic vein. Of course, the splenic vein is thrombosed. Why do we have to go and deal with the varices? Just open the splenic vein, put a balloon, inflate a balloon, do venoplasty, just open the splenic vein, and the pressure resolves, and eventually all the varices they come back to the normal size and they stop bleeding. And the other thing we can do as a last resort is partial splenic embolization, which I will deal with in detail in this video. Okay, so let us see how we embolize all the varices in a single session. The most latest technique what we do is called as antegrade transvenous obliteration. So just to deal with the basic of how we do this is that we take the patient to the cath lab suite, we give him some local anesthesia on the skin, we see on ultrasound guidance, we recognize the portal vein, we directly puncture the portal vein through the needle, a small needle, Chiba needle around 22 gauge or 21 gauge, we directly puncture the portal vein, we send wire across the portal vein into the left gastric vein. So what happens now? You know that this is the afferent vein. This is the one which is bleeding. You directly send the wires and catheters into it, cannulate it, and take a venogram. So when you take a venogram, you see all the varices well visualized on a DSA imaging. So what we do is we just inflate a balloon here and we start injecting sclerosant or embolizing material, whatever the operator wants to use. He can use STS or he can use glue and he can embolize all the varices in a single session. So what the balloon does over here, it prevents reflux. And next thing is, with this we target the varices specifically and accurately, and at the single session we can inject glue or STS into the varices and completely embolize it in a single session. This is antegrade transvenous obliteration, and we do this transhepatic route. This is through the liver. There are various other options too. The next antegrade access that we can do is through access the internal jugular vein in the neck. So mostly what happens when a patient has deranged coagulation profile, where the patient's INR is raised, prothrombin time is raised, his platelet counts is low, we cannot directly puncture the liver. That will increase his risk of bleeding after the procedure. So we only choose the transhepatic route if the patient has normal coagulation profile. If the coagulation profile is abnormal, we have to correct his platelets by platelet transfusion, correct INR with FFP transfusion, and only when it's normalized, then we can puncture the portal vein through the liver. But if the patient's coagulation profile is abnormal and it's an emergency, you cannot transfuse. Only thing you can do is puncture the IJV directly under ultrasound guidance, send wires and catheters into the hepatic vein, create a tip shunt between the hepatic vein and the portal vein, send wires through the tip shunt, and then directly cannulate the gastric varices and embolize it. This is as effective as transhepatic route, and it is safe. And after the procedure, you can simply remove all the wires, catheters and sheath and compress the IGV. This will reduce the risk of bleeding in the patient. But if the patient has normal coagulation profile, just directly puncture the liver and do the procedure. So either ways, we have options as intervention radiologists. We can come from either route, irrespective of the coagulation profile. We can still do the procedure through IGV access. So these are all antegrade approach, because here we are cannulating the afferent vein and treating it. So there are options to treat the patient retrogradely through, which I will be saying in the next slide. So the next thing is balloon assisted retrograde transvenous obliteration of varices. So when it comes to the anatomy of all these varices, when I already spoke previously, we know that this is the splenic vein, portal vein, superior mesenteric vein, and these are the veins. Left gastric vein, these are all afferent veins. Short gastric veins, posterior gastric vein, left gastric vein, these are all afferent veins. Afferent is AFF. So why we call it as afferent is the direction of flow is towards the varices. But we should know, where is the varices draining into. These varices, most of the times patient is having portosystemic shunt. So these varices, they drain into the systemic circulation. This is portal circulation. This will all drain into systemic circulation. Most commonly it is going to drain into the renal vein, most commonly the left renal vein. So you see the blood that is flowing through the afferent, left gastric vein, posterior gastric vein, short gastric vein into the varices, all of it gets drained into the systemic circulation through the left gastric vein. So this leads to something called hepatic encephalopathy, because you can see that this portal venous circulation carrying the blood from the colon and the spleen is mixing directly into the systemic circulation without getting detoxified in the liver. So what happens? Patient develops hepatic encephalopathy because of raised ammonia levels. So that is why this is called as an efferent. The first one is afferent AFF, the next one is efferent EFF. So we can also access these varices retrogradely. Go cannulate the left renal vein, put a balloon inside the draining efferent vein, EFF efferent vein, and inject the sclerosant. A lot of sclerosant needs to be injected. It goes reversely through this. Because the balloon is inflated, there is no way it will reflux. So we will inflate a balloon and inject the sclerosant or glue into the varices. This will embolize the varices completely, and the patient bleeding immediately stops. This is called as BRTO. It's a very famous technique in intervention radiology fraternity. There are variations to this also. If you inflate a balloon, it is called as BRTO. If you put a plug and then put a microcatheter through the plug and inject, it's called as PARTO, PARTO. If you put a coil, it is called as CARTO, CARTO. So there are various variations, and the most commonly used technique is BRTO. It is more affordable. But the best technique is Parto, where we use plugs. That is more efficient according to the latest studies. But just to deal with it, we can puncture the femoral vein, take the wires into the left renal vein, put a balloon into the varices, inject sclerosants and glue into the gastric varices, and embolize the gastric varices when the patient is bleeding. So this is how we do it. We put catheters into the femoral vein, take wires and catheters, reach up to the left renal vein, inflate a balloon in left renal vein. This balloons also have a side port through which we can inject sclerosant. Balloon will prevent the reflux of all the sclerosant into the systemic circulation, and then we also achieve complete embolization of the gastric varices. So this way the gastric varices are embolized, patient bleeding stops immediately, and most importantly all the varices are dealt with in a single session, minimally invasively, under local anesthesia, and patient can also be discharged the same day. It's a very simple procedure for an intervention radiologist who understands the deepest of anatomies through his imaging, because we study all this on CT scans. We know where the varices are, where the shunts are exactly, and we target them specifically, and we do not let anything untreated. So this is one advantage of knowing imaging and also treating the patient. This is about BRTO, retrograde techniques. So these are the drugs we inject. This is STS. This is sodium tetradicyl sulfate injection. What we do is we mix this with air and then inject. This is glue. Here we mix glue with lipidol based on the concentration the operator wants. Mostly we use 50% glue, where we mix glue and lipidol in a ratio of 1:1 and inject into the varices, and we achieve complete embolization. So we already dealt with how we can embolize the varices, but we know the cause for it is splenic vein thrombosis. Why can't we just go and recanalize the splenic vein, isn't it? So it's simple to say. But yes, as an intervention radiologist, we can also directly recanalize the splenic vein which is thrombosed or occluded, provided it is a short segment occlusion and the vein is good enough to be recanalized. Okay, most of these patients with left side portal hypertension come with poor quality veins, which is not good for recanalization. So that is why we want to embolize the varices directly. But if a patient reaches out to us early, we can probably recanalize the splenic vein directly instead of having to deal with the varices. So what we do in splenic vein recanalization is that we use ultrasound. Through ultrasound, we directly puncture the splenic vein, send wire through the splenic vein, cross the occlusion with the wire. This is transsplenic route. We can do the same thing through transhepatic route as well. Directly puncture the portal vein under ultrasound guidance, send the wire across and cross the occlusion. But remember guys, it's not easy to cross the occlusion because most of these veins are fibrotic, occluded for a long duration, and the wires don't usually just cross the occlusion easily. But if it goes through, then it is a bonus for the patient. But most of the time it is a difficult thing to do. That is why I've kept it as a second option. But eventually if the vein quality is good, it's short segment occlusion, it is not very fibrotic, it has some patent lumen, we can eventually pass the wire easily through it. So why cross the wire? Just pass the wire. But what is the advantage of passing the wire is that we will inflate a balloon. So we will send a balloon through the wire, over the wire, and then we inflate a balloon. Approximately a 10 mm balloon is what we use for a splenic vein. We use a 10 mm balloon, inflate it for a prolonged duration because it is fibrotic. This balloon will open the vein. So this will bring about recanalization of the vein. But the disadvantage of using balloon is that once we deflate the balloon and remove the balloon, the veins have a tendency to recoil. So when they recoil, eventually in 1 or 2 days, the vein again gets occluded. So what we do is that if after doing venoplasty, the pressure gradients across the stenosis is more than 5 mm Hg, or if the recoil is more than 30%, then we would prefer to place a stent across it. How do we place a stent? Is something like this. We inflate the balloon, we do venoplasty, we remove the balloon, and then we pass catheters where we can put a stent over here. So stent is just like how we use for the heart. We use a 10 mm stent for the splenic vein. These are all specialized venous stent. Don't usually get thrombosed easily. But when you place a stent, patient needs to be on anticoagulations and antiplatelets for a long duration. So this is how a stent might look like in a vessel. This will prevent recoil of the vein and also helps the blood flow to go across it easily. So the stent will keep the vein open and the blood flow establishes. All the collaterals that has been formed will collapse on its own. The pressure on the left side is reduced and the portosystemic circulation is re-established. So we can also do stenting. This is about splenic vein recanalization. But always remember, if we do venoplasty or stenting, patient needs to be on antiplatelets and anticoagulants, probably for a long duration, at least 2 years. And these patients usually have prothrombotic state. If it is not related to pancreatitis and patient had developed thrombosis, maybe he'll have to be on a lifelong anticoagulation. If it is related to pancreatitis, it's resolved, then maybe we can consider tapering down the anticoagulation after 2 years. So we can do venoplasty and stenting. So this is another option, second option. Let's come to the most important topic. This is some of the famous techniques that has been formed in the last 1 decade. You can see that when I said the surgeons, what they do is remove the spleen. But you don't have to remove the spleen anymore. We can do something called as partial splenic embolization. What do we do is that we puncture the common femoral artery in the groin. We take catheters and wires across the celiac trunk, reach up to the spleen, cannulate the splenic artery, take an angiogram. And what we do is we embolize the spleen up to 60%. What we do is that we block all these arteries for about 60% of splenic parenchyma, and we infarct the 60% of spleen. So what happens when 60 to 70% of the spleen is infarcted? It stops functioning. The rest 30% starts doing the function. The advantage of this is that the splenic parenchyma is retained, so patient's risk of infection reduces. Next thing is we have also achieved something called as splenectomy by just embolizing it up to 60 to 70%. So there is functioning spleen as well, and there is infarcted spleen as well. We always prefer doing embolization of the lower pole of spleen, because if we embolize the upper pole, patient usually has some amount of pleural irritation and reactive pleural effusion after the procedure. So that is why we always prefer embolizing the lower pole of spleen. So we inject particles called as polyvinyl alcohol particles, and sometimes we use gel foam, and we embolize the lower pole of spleen. So what is the advantage of embolizing the spleen is that when we embolize the spleen, 60 to 70% of spleen is gone, 30% is left. So eventually the blood flow to the spleen is reduced. When the blood flow to the spleen is reduced, the outflow through the splenic vein is also reduced. So when the outflow through the splenic vein is reduced, definitely the left side portal hypertension also reduces on its own. It is just like splenectomy, but we're doing partial splenectomy by just embolization. And remember guys, it has no complications of infections like splenectomy, and it is a minimally invasive procedure done with local anesthesia. We inject 10 ml of local anesthesia in the groin, puncture the common femoral artery, take wires, small wires and catheters into the spleen and embolize it, and patient can walk back home on the same day. So it is a trending procedure. It is a non-surgical alternative to splenectomy. Interventional radiologist takes access to the femoral artery, reaches up to the splenic artery and embolizes it. What it does, it reduces the splenic volume, also reduces the splenic venous blood flow, indirectly reducing the left-sided portal hypertension venous pressure. Advantages, there's no infection or sepsis. It's a local anesthesia. It's done under local anesthesia, and it's a daycare procedure, as I said. So this is about the role of intervention radiology in left-sided portal hypertension. There is role of intervention radiologist head to toe. We can treat a lot of diseases head to toe, and this is the modern medicine. Since last 1 decade, the radiology has progressed so much that people, I mean, the radiologists in the previous decade were diagnosing diseases. Now we have stepped out to treat diseases in the form of intervention radiology. It's a branch that is the future of medical science. Everything done in a minimally invasive manner under imaging guidance and with utmost accuracy and zero complications. Most of the times we achieve zero complications because we use imaging to achieve accuracy. So if an intervention radiologist is very well trained and experienced, there is high chances that the procedure can be done with 100% accuracy. So we have around 40 to 50 neat super specialty seats of DM and DRNB in intervention radiology, and you can give neat super specialty exams and take these seats. And I would always encourage a radiologist to take up intervention radiology because it will make you very powerful in treating patients, and this way you can diagnose, treat, discharge patients on your own. You become a clinician again, and this is the future. So I hope this video about our role of intervention radiologist in medical science motivates most of you to take up this branch. And I also hope for non-radiologists, if they have seen this video, it helps them understand the role of intervention radiology in most of these diseases. And I hope this message and knowledge reaches everyone. Thank you once again for always supporting me. Uh, but one thing is, you should know that which of these three options is best is that all of these three options are actually good. If this clinic vein can be recanalized and it is recanalizable, I think this would be a good option. But most of the times you should know that patient lands up in the emergency with bleeding. So what we have to do at that point of time, instead of trying to recanalize the splenic vein, is we have to try to save his life by stopping the bleeding. So varicose embolization is the most common thing we do. We always try to embolize the varices, stop the bleeding, and patient is happy that the bleeding is stopped. He's not vomiting blood anymore. He doesn't have melena anymore. So most of the times patient lands with bleeding, and that is when varicose embolization comes into play. We can achieve 100% accuracy and treat the varices through imaging guidance. Splenic and recanalization is also a good treatment, but there is high chance that after venoplasty the vein can recoil. Most of the times we might require a stent, and also stent has a chance of thrombosis, and patient needs to be on anticoagulation for a longer duration. Uh, but what I feel is the best technique we can do is a varicose embolization and combine it with partial splenic embolization. I think this will give better results. There are various researches and studies going on which is best and what should be done first. But I say a combination of treatment is always the best, and whatever we choose as best is actually case-based scenarios. So whatever is best for the patient needs to be offered, is what I have understood. And I hope the role of interventionalist and the message will reach everyone. And thank you for joining me again. Thank you.